The following podcast is part of a certified educational activity titled The Oncologist, Nurse, and Patient Partnership in AML, Multiple Perspectives on Integrating Targeted Therapy into Care. Access the entire activity and complete the post-test at www.peerview.com/UMC. Downloadable slides and practice aids are also available.
Hello, this is Dr. Amir Fathi from the Massachusetts General Hospital Cancer Center. Welcome to this educational activity on the recent emergence of targeted options in the management of acute myeloid leukemia. During this program, my fellow panelists and I will explore perspectives from other members of the management team, as well as those of patients with AML. In a few moments, I'll introduce my nurse practitioner colleague from Massachusetts General Hospital, Jenna Moran, and Mr. Richard Dickens from Cancer Care, who will offer his thoughts on the patient's perspective for many of the topics we will be discussing. But now let's begin with a look at some of the recent changes in AML, particularly the recent validation of several novel agent classes for disease management. We will start with prognostic assessment, which is increasingly important in an era of targeted therapy. The traditional assessment of AML oftentimes involves age and performance status. More recently, chromosomal and molecular aberrations have also become prognostically important in patients with acute myeloid leukemia. The NCCN guidelines recommend testing for markers such as FLT3 mutations and NPM1 mutations, along with many others, and the European Leukemia Net recommends FLT3 testing, both TKD, which stands for tyrosine kinase domain, and ITD, which stands for internal tandem duplication mutations for all patients with AML, with results required within a short window of days. In general, certain mutations have prognostic relevance in acute myeloid leukemia. For example, FLT3 ITD mutations, which represent approximately a third of patients with AML, generally portend a worse prognosis. Patients with FLT3 mutations relapse at a higher rate than patients who do not have ITD mutations. On the other hand, NPM1 mutations, if found in isolation, are associated with better prognosis. IDH mutations, which have only recently been discovered in myeloid malignancies, impact approximately 20% of patients, but their prognostic relevance is less clear. Results of genomic testing can help guide therapy for patients with AML. For example, patients who have FLT3 mutations or IDH mutations have available certain targeted therapies that target those alterations. Let's take a look at some of the evidence for therapies targeting these genetic aberrations before turning to the future of targeted options in AML. Over the course of the last decade, there have been a series of FLT3 inhibitors that have been studied in patients with FLT3 mutated AML. The first generation of FLT3 inhibitors were less specific and less potent. Midostaurin is a fairly potent FLT3 inhibitor, but non-specific in its activity, meaning that it inhibits a wide variety of receptor tyrosine kinases, including FLT3 tyrosine kinase. The more recently developed FLT3 inhibitors such as Gilteritinib, Quizartinib, and Crenolanib are more targeted and more potent, as is demonstrated by the kinomes below. On the left are the less specific FLT3 inhibitors that inhibit a wide range of tyrosine kinase receptors and tyrosine kinases. On the right are the more specific second generation FLT3 inhibitors such as Quizartinib, which inhibit a more narrow group of tyrosine kinases and also have specific potency against those kinases such as FLT3. Midostaurin, among the first FLT3 inhibitors under development, was assessed in combination with 7+3 induction in the phase 3 RATIFY study. And the results of this study had impact. Patients who received midostaurin in addition to 7 and 3 had improved survival compared to those patients who received 7 and 3 induction with placebo. Event-free survival was also improved in patients who received 7 and 3 and midostaurin. This led in spring of 2017 to the FDA approval of midostaurin in combination with induction chemotherapy in patients with newly diagnosed FLT3 mutated AML. Patients would receive midostaurin in combination with induction and thereafter go on to receive consolidation therapies. More selective and potent next-generation FLT3 inhibitors have also been recently studied in AML, either as monotherapy or in combination with traditional chemotherapies. Gilteritinib is a selective FLT3 inhibitor which is active against both forms of FLT3 mutations, FLT3-ITD and FLT3-TKD alterations. The FDA granted priority review of the NDA in May of 2018 based on ongoing phase 3 clinical trial, which compared gilteritinib with salvage chemotherapy options in adult patients with FLT3 mutant relapsed and refractory AML. There is also important data emerging from the phase 2 Chrysalis study. Monotherapy with gilteritinib leads to impressive response rates in patients with relapsed and refractory FLT3 mutant AML. Quizartinib, another selective and potent FLT3 inhibitor, has also been studied in various clinical trials, including monotherapy studies, as well as a comparison phase 3 study that compared monotherapy with quizartinib versus various salvage chemotherapy options in patients with FLT3 mutated AML. This phase 3 study was presented at the European Hematology Association in 2018 and was met with much excitement and interest, especially since the median overall survival of patients who received quizartinib was prolonged compared to those individuals who received investigators' choice of salvage chemotherapy for relapsed and refractory FLT3 mutated AML. Let's talk about IDH inhibitors in development and some of the recently approved targeted agents for relapsed and refractory patients. IDH mutations were discovered fairly recently in myeloid malignancies, and specifically acute myeloid leukemia. Alterations in IDH gene lead to an altered IDH protein, IDH-1 proteins and IDH-2 proteins, which lead to the promotion and accumulation of the oncometabolite 2-hydroxyglutarate. 2-hydroxyglutarate builds in the blood, leads to suppression of key enzymes, epigenetic changes, and impaired differentiation. Mutant IDH has been identified across a range of solid and hematologic malignancies. Testing for IDH mutations is relatively straightforward, given that nearly all mutations are located on exon 4. IDH-1 mutations are seen at a single residue, whereas IDH-2 mutations are seen at 2 residues. Several methods, including PCR, Sanger, and next-generation sequencing, are now commonly used for IDH mutation detection. Many academic institutions perform mutational analysis with next-generation sequencing. Private laboratories also perform multiplex panels for diagnostic and prognostic purposes in patients with various myeloid malignancies. There are various IDH inhibitors currently under study and 2 that have been approved. Enasidenib targets IDH2 and has been approved for adult patients with relapsed and refractory IDH-mutated AML. Ivosidenib, the IDH1 inhibitor, was also approved in patients with relapsed refractory IDH1 mutated AML. FT2102 and an agent BAY1436032 are both IDH1 inhibitors that are currently in clinical trial development. The monotherapy experience of enasidenib ultimately led to its FDA approval. In dose escalation and dose expansion studies, a dose of 100 milligrams daily ultimately emerged as effective and safe. Enasidenib monotherapy led to an overall response rate that approximated 40% and a remission rate that approximated 20%. Responses included complete remissions with incomplete recovery, but also less traditional responses such as partial responses and morphologic leukemia-free states. The median overall survival among relapsed refractory acute myeloid leukemia patients was approximately 9 months, which is quite remarkable. Updated efficacy outcomes with the 100 milligram daily dose were reported at the recent European Hematology Association meeting. In this presentation, late responders had a significant overall survival benefit compared with patients with no later responses. Patients who maintained stable disease at all response evaluations received a median of 5.5 months of enasidenib therapy and had a median overall survival of 9 months. Similarly, Ivosidenib has an impressive response rate in patients with IDH1 mutated relapsed and refractory AML, with a CR or CRh proportion of approximately 30% of patients and an overall response rate of approximating 42%, similar to Enasidenib in relapsed refractory IDH2 mutated AML. In a recent publication, Dr. DiNardo and colleagues revealed that Ivosidenib was active at a dose of 500 milligrams daily in this patient group. The activity of IDH inhibitors is related to the release in the block of maturation that occurs as a result of treatment. As mentioned previously, IDH mutations due to accumulation of the oncometabolite 2-hydroxyglutarate lead to aberrant hypermethylation and suppression of maturation and differentiation. IDH inhibitors release this block in differentiation and maturation, and over a course of weeks in patients who respond, lead to a differentiation of myeloid blasts in responding patients. As can be seen here in the leftmost panel, there is a monomorphic population of myeloid blasts in a patient newly diagnosed with disease. Over the course of therapy, there is an eventual gradual progression of response in a patient who is responding. By cycle 3, you see a reduction in blasts in the marrow as well as maturation. On the lower panels, you see the persistence of the aberrant chromosomes seen the initial leukemia population carry during the process of maturation into mature granulocytes, confirming the process of differentiation as the mechanism of action for patients being treated with IDH inhibitors. This mechanism of action is also responsible for a prominent adverse event seen in a minority of patients treated with IDH inhibitors. In this figure, we see a representative course for a patient treated with IDH inhibitor and developing a differentiation syndrome. Approximately by the beginning of cycle 2, which is 4 weeks after the initiation of treatment in this one particular patient, we see a rise in mature granulocytes as well as an improvement in the marrow response, suggesting a process of differentiation. Around the same time, the patient develops unexplained fevers, pulmonary infiltrates, and respiratory symptoms. The CT images below reveal the pulmonary infiltrates. The patient is treated with dexamethasone for differentiation syndrome and is also concurrently treated with hydroxyurea for an elevation in his white blood cell count. The patient achieves a response from the course of steroids and thereafter achieves a response by approximately cycle 3 of treatment. So the process of differentiation leads ultimately to response, but in some ways is also responsible for the development of differentiation syndrome in a minority of patients. Differentiation syndrome can be severe and lethal if not recognized early and appropriately treated with steroids and close monitoring and potential hospitalization for patients who are decompensating quickly. Let's now bring our attention to Venetoclax, a selective inhibitor of BCL2. The BCL2 protein is highly representative in patients with various malignancies, and the levels are known to be elevated in various hematologic malignancies, including lymphoid malignancies, but also acute myeloid leukemia. Venetoclax is highly selective, orally bioavailable inhibitor of BCL2 with cytotoxic activity in various BCL2-dependent cell lines and preclinical models. This clinical activity was demonstrated as monotherapy in patients with CLL, leading ultimately to its approval by the FDA. In 2018, Venetoclax was FDA approved in combination with hypomethylating therapy or low-dose cytarabine with patients with acute myeloid leukemia who were newly diagnosed but were ineligible for chemotherapy. The combination of hypomethylating therapy with Venetoclax was initially studied in relapsed and refractory patients, as well as other hematologic cancers, and led to a modest response rate of 21% and an estimated 6-month survival of 24%. Combinations of Venetoclax with hypomethylating agents and low-dose cytarabine have also been recently evaluated in patients who are newly diagnosed but who are older and are perhaps less fit for intensive therapy. Let's look at some of this data. The early phase trial of hypomethylating agents with Venetoclax in newly diagnosed older patients with AML looked at a range of doses for Venetoclax in combination with hypomethylating therapy, and across this cohort of groups led to a very impressive composite response rate that ranged from 60 to 75%. Another recent report assessed the combination of Venetoclax with modified but still intensive chemotherapy, the so-called 5 and 2 regimen, in older patients who were fit for chemotherapy. This led to an overall response rate of 71% and a median overall survival of approximately 8 months. Very low levels of tumor lysis syndrome, which has been seen with treatment of Venetoclax in patients with lymphoid malignancies, has not been seen to such a high degree in patients with myeloid malignancies, such as myelodysplastic syndromes and acute myeloid leukemia. We will look at adverse events associated with Venetoclax and other targeted agents in the next segment. There's an ongoing phase 3 study of Venetoclax plus the hypomethylating agent azacitidine in newly diagnosed patients with AML. This study recently completed accrual, and we eagerly await the results. The very brief review of evidence I've just shown should give you some idea of how far we've come in just a few short years. When cytarabine-based chemotherapy was still the only standard of care in AML a few years ago, we now have multiple targeted therapies available for our patients. But how have these changes affected the wider oncology management team, as well as, importantly, our patient population? Stay tuned, because we will soon explore these topics in subsequent presentations. Welcome back. It's now my pleasure to welcome my colleague to the panel, Jenna Moran, a nurse practitioner with our group at Massachusetts General Hospital. Jenna, welcome.
Thank you. I'm looking forward to our discussion.
Let's begin. Earlier, I shared some of the current recommendations for the prognostic assessment of acute myeloid leukemia and how some features, like the presence of FLT3 and IDH mutations, were relevant for treatment. Jenna, how do you educate patients who may ask questions about their prognosis or what to expect from therapy with targeted agents?
Sure. I think it's very important to be honest and transparent with the patients up front. Some evidence has recently shown that patients greater than 60 years old overestimate the likelihood of cure. And this is most noticeable with patients having received non-intensive chemotherapy, such as the oral agents. Having a face-to-face conversation is also recommended, as patients tend to prefer this type of interaction. It's important to explain to patients when you meet them that remission is not always synonymous with cure, so that the expectations of the treatment are clear up front. It's also important to be prepared to explain to patients that accurate diagnosis and prognosis is critical to uncover important markers such as FLT3 or IDH mutations that can be used to help guide therapeutic decisions. Many targeted agents are orally administered, and this allows for outpatient care, which is actually typically a benefit for most of our patients, as they prefer to be at home and helps with their quality of life. It's also very helpful to verbally explain all of the information to the patients, as well as providing them with written instructions.
What are some of the approaches that we take to explain the diagnostic steps to patients that are diagnosed with acute myeloid leukemia?
During the course of treatment, there are many diagnostic tests. A lot of them we do up front, but then are repeated when we're looking for remission or relapse at different stages. It's very important to explain, when testing for example, bone marrow biopsies initially, to explain to patients that this is when we do the molecular testing, and molecular testing can help further make decisions on what agents to use when augmenting their treatment. Patients may have questions about FLT3 or IDH-specific mutations and their relevance to chemotherapy in the future. And it's important to be prepared to discuss these options with the patients. But other factors may include prior chemotherapy for other cancers, prior MDS or another blood cancer, if they have different general health issues that might impact our treatment decisions, if they have genetic abnormalities, or if they've been previously treated for AML in the past, and this is new treatment for a relapse.
Thank you, Jenna. Let's turn to some of the specific targeted therapies I mentioned earlier, starting with FLT3 inhibitors. We've seen some of the efficacy data. What about the safety?
It's important to review a lot of the possible side effects up front. I usually like to focus on the most common side effects for every given drug with my patients. For example, with Midostaurin, it's most important to focus on clinical effects like rash and nausea, which have been found most common in patients, when provided with this patient up front, it allows patients to know what to report to us as providers so we can help to sort of manage their adverse effects.
I agree. I think it's very important to consider nausea, other gastrointestinal symptoms, as well as skin manifestations, since these symptoms are also quite common during treatment with induction chemotherapy by itself. So the combination with midostaurin, which can have these additional adverse events, is important to consider when treating these patients.
So for considerations in managing these adverse events with the common FLT3 inhibitors such as midostaurin, watching for things like rash or sensitivity, sometimes to encourage the patients to use extra moisturizers, but also define that line in which something is more severe and should be reported to us. Also, just GI toxicity is a very big common effect for patients, and to sort of explain up front how to take an antiemetic and prescribe that when you're prescribing the midostaurin. As well as with oral medications, as I previously talked about, it's important to give written instructions on how to take these drugs at home.
Let's talk about some other targeted therapy classes. What can you tell us, Jenna, about the adverse event profile of IDH inhibitors?
Sure. So for example, with Enasidenib, which was recently approved for relapsed refractory IDH2 mutated AML, a common finding was hyperbilirubinemia in recent clinical trials prior to approval. So it's important to monitor baseline liver enzymes and then periodically monitor the liver enzymes with treatment and assess for a rise in the bilirubin.
That's a great point. In addition to the unique adverse event of hyperbilirubinemia, a proportion of patients also had GI side effects and cytopenias, although in total, the adverse event profile of Enasidenib suggested that the drug is very tolerable in patients treated with the drug. Let's talk about Ivosidenib. What are some of the unique side effect profiles seen with Ivosidenib?
Sure. So for Ivosidenib, there are other common adverse effects like diarrhea, leukocytosis, and nausea, but there are also some more serious considerations such as QT prolongation. It's important to get a baseline EKG to assess the QTc of a patient and then follow periodically. Also, as a provider, it's important to pay attention to other drugs that are added to the patient's regimen that may also prolong the QT and monitor more closely. Another very serious and sometimes fatal event that we've seen is differentiation syndrome. It's less common, but definitely potentially more serious.
I agree. It's very important to recognize differentiation syndrome. It can be seen with either IDH1 inhibitor therapy or IDH2 inhibitor therapy. It can occur concurrently with leukocytosis. So when we treat or monitor for differentiation syndrome, we should also monitor for leukocytosis. The treatment of differentiation syndrome, if it is suspected, is generally steroid therapy. If it's not improving, we might consider other approaches such as holding the drug. Concurrent with that, obviously, we may consider treating leukocytosis with hydroxyurea. So here are some signs and symptoms consistent and associated with IDH differentiation syndrome. Some of these I've already mentioned in the previous segment, but any thoughts you have on what you could potentially see with the symptomatic manifestations of IDH-DS?
Sure. So pulmonary toxicity is definitely one of the components of the differentiation syndrome. Patients will often present with dyspnea. They might also have some unexplained fevers, so it's important also to rule out that there's not another process going on, such as infection, and do appropriate workup and potentially treat for infectious etiologies first as well. Oftentimes pulmonary infiltrates, pulmonary edema, pleural effusions are seen on CAT scans, so getting a CAT scan early can help to sort of lead to this discovery of what is really going on. Also, rash can also be seen, sometimes edema and weight gain.
Yeah. So it's a sort of a non-specific manifestation in patients who have had a sufficient workup for other potential explanations of what is happening, such as infection or cardiac toxicity. There has been a fairly extensive review of data regarding differentiation syndrome and its management. This is now outlined in publications. What is your recommendation for the potential discovery of IDH differentiation syndrome and its management depending on the severity of presentations?
So recognition is looking for laboratory studies such as leukocytosis with an elevated white count and further exploring that if it's driven by disease or not. In addition, doing an early CT scan to look for any pulmonary issues such as pulmonary infiltrates, pulmonary edema is often seen, pleural effusions as well. And starting treatment early in these patients with dexamethasone, we typically give 10 milligrams twice a day, sort of empirically until we can decide what's going on. Also covering patients for other possibilities that could explain their leukocytosis and unexplained fevers, such as if this is an infection on top of a differentiation syndrome, and doing the appropriate workup for fever, and starting antibiotics if needed. Also starting drugs like hydroxyurea. If the white blood cell count is so elevated, it's concerning that it could cause problems. And then hospitalization may be indicated for some of these patients if their symptoms are severe enough.
So exactly right. I mean, I think it's very important to recognize the potential signs and symptoms of differentiation syndrome, and also recognize that some of the signs and symptoms of differentiation syndrome can accompany known clinical sequelae seen in patients with AML, such as infections or heart failure, and to empirically treat for those if suspicion is high enough, but at the same time potentially empirically treat for a differentiation syndrome, especially if those other secondary causes are ruled out. Let's turn to Venetoclax, approved for acute myeloid leukemia and approved for chronic lymphocytic leukemia, another hematologic malignancy. Jenna, what are your thoughts on issues such as tumor lysis syndrome or other adverse events that we've seen with Venetoclax?
I think one of the most important things that we've seen with Venetoclax is tumor lysis syndrome. I think it's been studied more in CLL patients than necessarily seen in AML patients. However, we always should plan in advance for that possibility by educating the patients if they're at home to maintain adequate hydration, increase fluid intakes, usually starting an anti-hyperuricemic at the start of therapy, and monitoring tumor lysis labs in clinic when they're being evaluated.
I agree. As opposed to the CLL experience, the incidence of tumor lysis syndrome, at least clinically impactful tumor lysis syndrome in patients with AML, is more modest. What other approaches would you consider when you're treating an AML patient with Venetoclax, especially considering potential concurrent medicines?
Sure. So I think we have a lot of patients that may have fungal infections requiring antifungal therapy, and a lot of the antifungal medicines can interact with Venetoclax, causing it to potentiate the effect of Venetoclax, and therefore we may need to dose reduce. So it's important to know what medications the patients are on so we can adjust.
This is an important point. Many of our patients are on certain antifungals called azole therapies that can impact the levels of Venetoclax, and therefore, as you mentioned, Venetoclax dosing may need to be adjusted. Thank you, Jenna, for these very practical insights. Next, we will explore several case scenarios in AML and try to understand patients' experience of targeted therapy. Stay tuned. As we start this segment, I'd like to introduce Mr. Richard Dickens, social worker and director of client advocacy at Cancer Care. Richard, welcome to the panel.
Thank you. I'm happy to participate.
Let's consider Michael, a functionally fit 55-year-old male with a new diagnosis of acute myeloid leukemia. He initially presented with fatigue, epistaxis, and easy bruising. His blood counts revealed an elevated white blood cell count and a peripheral smear that was concerning for acute leukemia. He thereafter underwent a bone marrow biopsy, which revealed 94% myeloid blasts and hypercellularity. His karyotype was a normal male karyotype, but he did have FLT3-ITD and NPM1 mutations. Other than the symptoms that he experienced at presentation, Michael was previously fit and clinically well, and was therefore deemed to be a good candidate for induction chemotherapy with 7+3. However, given the presence of a FLT3 mutation, his oncologist did recommend the addition of the FLT3 inhibitor Midostaurin. Michael considers himself to be health literate and understands the benefits and risks of chemotherapy. However, he does admit to being confused and uncertain about his prospects when he learns of the prognostic and therapeutic implications of FLT3 mutations. Richard, what is a patient like Michael, who has a certain degree of health literacy, experiencing when confronted with a new diagnosis?
Great question. From a social work standpoint, we really look at the holistic person. That was a great presentation in terms of the medical procedures and drugs that he was going to be involved in, and even with some degree of health literacy, a lot of that is going to be over the patient's head. What we do, though, as social workers, is we try to understand who the patient is and the patient's values, especially as many cancers are becoming chronic illnesses. It's not just the acute phase, but it's also after that and ongoing treatment and perhaps even survival. So a lot of times what we want to do is try to figure out who is this patient, the whole patient, and share that with the team. What are their values? Do they have hobbies? Hobbies could include exercise. And Michael, you mentioned as being fit, and that's an important thing to him. Also, in terms of his health literacy, I'm going to back up just a little bit. I've never worked with a person who's heard the words, "you have cancer," and isn't right away thinking about their own mortality. Let alone uncertainty is almost endemic in everybody when they hear "you have cancer." And it's not just the cancer patient either. The more I do this over the years, the more I do this work, and the more research that's done, especially as cancers become chronic illnesses oftentimes, is they're looking more at the whole system. Social workers work a lot of times in systems. And in this case, there's the family system. Potentially for a 55-year-old, there might be a work system, and there's a social system. There are a lot of systems, and although only one person could get cancer, everyone who loves or works with that person is potentially affected by that cancer diagnosis and the subsequent treatment.
Thank you so much for that insightful and powerful information. Let us now consider Ellen, a 68-year-old woman with relapsed IDH2 mutated AML on treatment with Enasidenib. She was previously treated with 6 cycles of hypomethylating therapy for a newly diagnosed AML. At the time, her ECOG performance status was 1, and she subsequently achieved an initial remission. However, laboratory and bone marrow testing revealed relapse, with molecular evaluation now showing an IDH2 mutation. She thereafter initiated therapy with Enasidenib at the approved dose of 100 milligrams once daily. She achieved a second remission following 6 cycles of treatment with Enasidenib, and her ECOG performance status improved, as did most of her symptoms. However, recently Ellen has experienced low-grade leukocytosis, which appears to be slowly resolving with time. Nevertheless, Ellen is anxious over her recent elevated white blood cell count and worries about the development of adverse symptoms, possibly related to differentiation syndrome. What are your thoughts about the course for Ellen and what she is experiencing?
It's a wonderful case, especially next to Michael. Ellen's 68, so there could be some other health issues that she's concerned about, even if they're not acute health issues. Also, in terms of that difference of just 13 years between Michael and Ellen, is does she have a significant other in her life? Does she have family as well? And also, what is her role in the family? A lot of times at 68 years old, she could have a spouse who also has health issues, and she could have adult children who are raising younger children, her grandchildren. So she doesn't want to be a burden on people like that. All of those stressors could contribute to anxiety. A lot of times the role of nursing really is a transitional role, and not a transitional in a holistic sense, but they work closely with the oncologist and the doctor, and they administer the medications. But they also work closely with social workers, and they also build a relationship with the patient during those treatments that really begins to explore the whole person. In Ellen's case, I would say one would really want to just build a relationship, what we would call a therapeutic relationship with her, to really find out what is she anxious about. And then probably to help with the anxiety, explore tools that she might already have in her reservoir of life for the most part. Tools, I would say, with somebody like Ellen could be spirituality or a religion. And when it comes to anxiety, reaching out to some people, friends or clergy and those roles. Also, I think she might benefit from meeting other cancer patients. Even though it's a rather rare cancer, it's unlikely probably that she would get right into a group of people just with this type of AML. But meeting other cancer patients, there are a lot of overlapping things that they're all dealing with. And then also there are a lot of patient-to-patient networks now that really talking to another patient, especially one of the biggest things we hear from patients is that nobody understands what they're going through. And the truth is, unless other people around them have had cancer, they don't understand, and they can't understand. But it's that simple connection to another patient that you don't always have to explain yourself, but that connection to knowing what that anxiety is about. Potentially anxiety could also become depression at some point. And Jenna, nursing is so important in this area.
Oh, absolutely, yeah.
Jenna, I think in our caring for patients, we frequently see a heightened level of anxiety and worry and uncertainty among our patients, even in those who respond to treatment. And I think you'd agree with me that involvement of support services, patient groups, social work is increasingly important.
Sure. Yeah, there's a lot of anxiety and fear that really comes with initiating, new and recently approved therapy. It's important for the patients to know up front that they have, the number to call the clinic at any time just to review, and even if they don't want to come in, just review any of the symptoms that they're experiencing over the phone with, experts, in this field. And that in itself sometimes just creates some reassurance that these things are expected and, not at a serious level enough to have to be seen.
And going back to the expertise of social work in systems, Ellen would be a perfect example or a perfect case in terms of if she does have a solid support network, and if it's family, especially for a social worker to have a family meeting, to really have them all talk, because a lot of times cancer is the elephant in the room. And they're all thinking about the same thing, but until somebody really gives it a name, they don't often talk about it, concerned about the other person, the caregiver by the patient, and the patient by the caregivers.
That was a very good discussion. Let us now move on to Robert, a 75-year-old man with de novo AML who is unfit for intensive treatment. Robert is a retired high school biology teacher after a 40-year-long career as a teacher. He has a medical history of congestive heart failure, which requires ongoing treatment. He also presents with adequate renal and liver function, but his ECOG performance status is limited. Testing shows a very elevated white blood cell count, a platelet count of 20,000, and a hemoglobin of 8. Additional testing, including a bone marrow evaluation, reveals 51% myeloid blasts in his marrow, but no FLT3 mutations. Robert is deemed to be ineligible for induction chemotherapy due to comorbidity and a compromised performance status. He is considering enrollment in a clinical trial using a hypomethylating agent combination, which is recommended as a potential therapy for his acute myeloid leukemia. He is eager and enthusiastic about participating in research and asks for additional advice about enrolling in clinical trial involving hypomethylating agent and a novel therapy. Given his history as a teacher, he is also very interested in self-education and educates himself on efficacy and safety data behind novel therapies for acute myeloid leukemia. What are your thoughts about the older patient who is perhaps not eligible for traditional, conventional treatments, but may be considering a clinical trial?
Mm-hmm. That's a great question and a great case study also in terms of Robert. There's a lot of things that stood out, or a couple of things that stood out there, is he was an educator and he's a learner. And he also, if I remember right what you had said, he also likes to participate and perhaps make some change or affect treatments down the line for other people. So finding meaning is so important for people. It sounds like he is very realistic about where he is in the life cycle, but I would go back too, and all three of these cases kind of highlight the fact where people are in the life cycle really has a lot to do with how they approach their cancer. Definitely cancer meant something very different to a 75-year-old who witnessed it 30 years ago in family or friends, and a 55-year-old right now who's just hearing about it. The changes in oncology have been profound. But I would approach him definitely in terms of finding meaning. I would definitely provide some education to Robert. It's really a very small case study in terms of what a social worker would know, in terms of the holistic person. Who is Robert? And definitely when you're talking about age and clinical trials, they mean very different things to people of different races and different cultures. So one really wants to be very sensitive to that. There are some cultures, even historically, that have been treated poorly in clinical trials. And although it's generations ago, that gets passed down. There are also other cultures or people who come here who are first-generation Americans or maybe even immigrants themselves, and their parents really come from a culture that they're still inculcated in, and it's hard for them to kind of embrace some of these different options, things like that. So that's very important, but definitely Robert gives you a lot to build on in terms of, it sounds like a man who is really comfortable with where he is, and he's comfortable definitely with the opportunity this presents, not just to him, but to other people as well.
Thank you so much, Richard. I think one other point that I would just like to raise, especially in older patients with acute myeloid leukemia, it is often important when a curative or intensive paradigm is not available to them to talk about goals of, that the patient may have in terms of what they want, you know, in terms of their life and in terms of the responses they would get from treatment. But thank you so much. That was a wonderful discussion. I think we've heard some interesting viewpoints today that can certainly help us to better care for our patients, particularly as we design strategies that increasingly feature novel and targeted therapies. Thank you, Richard. Thank you, Jenna, for your contributions to this discussion.
I thought this was an excellent discussion. Thank you for including me.
Thank you. Likewise, I found it very informative and a pleasure to be part of it.
Thank you for joining us today. Thank you. We hope you found the activity informative and useful to your practice.
Thank you for listening. Download materials and complete the post test for instant credit at www.peerview.com/UMC. This activity is supported by independent educational grants from AbbVie and Celgene Corporation. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.